Well, good evening, everyone. My name is Charlie Clarke. I'm a neurologist, and I've helped organise this gathering, and thank you very much for coming. I have been a great supporter of the CHPI. I've recently been elevated to the post of patron. I've never been a patron of anything, but I was attracted some years ago by a combination of things, by focus, by brevity, dedication to an evidence-based approach to very contentious issues, such as the internal market of healthcare and things like PFI. Now, I won't detract from our speakers, but when you have time, do please read the two CHPI papers, the last 5 years, which is on your seats, and the earlier 2016 report, which also makes very good reading. And these documents are, to my mind, they're excellent. They're brief, they're serious, and I draw your attention, I think it's on the last page, to the trivial amount of funding that this organisation has. This is not research on a shoestring, it's research on a G-string, or even less. And when one receives praise from the United States, a nation that doesn't even have an NHS or its own integrated system of care, you realise that the CHPI has achieved something remarkable already. And I quote Noam Chomsky, who, do you realise he's going to be 94 in December of this year? And he said, the NHS is one of the great achievements of post-war British society. Defending the NHS and the public interest generally with solid evidence has never been more important. The CHPI has been making invaluable contributions to this urgent need. And so I'm going to hand over to Jonathan Tomlinson, and he's going to chair this meeting. So thank you for coming. Jonathan.
Thanks very much and welcome everybody, and thank you very much for coming and for all of your support. I'm Jonathan Tomlinson. I was with CHPI when it was born in 2012 with Colin Lees, and I'm going to hand straight over to David Rowland, who's the director of CHPI and responsible for so much of the good research. He's on a panel with Goody Singh, who's one of our trustees, and with Phil Hammond, who some of you may know, who's another terrific supporter. Thank you very much.
Great, thank you very much, everybody. And just to echo Jonathan's comments about how nice it is actually to see people in the flesh. I think this is the first public speech I've given in well over 2 years, at least one that is not in front of a camera. So it is very nice to actually be surrounded by people. And of course, thank you very much to Charlie for hosting us this evening. It's incredibly generous of him to provide such a fantastic venue, particularly, as Charlie points out, for an organisation which has such a small amount of resource. What I'd like to do this evening is just really talk through some of the work that we've been doing over the last few years. And after I've given my presentation, we'll then hear some thoughts from Goody and then from Phil, and then we'll open up the discussion to the audience for comments and questions and to get your feedback on what we've been talking about. I thought it would be quite important to raise the question as to why we have entitled tonight's event Putting the Public Interest at the Heart of UK Healthcare, because I'm sure for many people in the room that's a given. Of course it's the case that the public interest should be at the heart of healthcare and social care. Of course it's the case that patients should also be the forefront of everybody's minds when we're talking about healthcare. However, it isn't something which we've necessarily experienced in our research over the past few decades, because I think what we've witnessed And one of the reasons why Jonathan and Colin Lees, who can't be with us tonight due to a mild bout of COVID, witnessed when they were working within the health service or studying the health service, was that there was a clash, a tension, a conflict, if you like, between the public interest and the private interests of organisations and individuals. And this conflict between the public interest, between the interests of patients and care users and taxpayers and private interests, has come about primarily because of a major shift in how government organises and delivers healthcare services in the UK, and in particular in England. And put simply, through using market-based mechanisms to deliver health and social care over the last 3 decades, governments of all colours have introduced powerful new actors which by definition often have financial interests which are different from or run contrary to the public interest. Now, these powerful actors, including large healthcare multinationals, private equity investors, outsourcing companies, who now operate in the fields of health and social care, increasingly have the ability to shape the quality of health and social care, how they are regulated, and also who is able to access them. And it was because of the extension of market-based mechanisms to large swathes of the public sector, including health and social care, including the public utilities, including education, and because of that growing conflict between the financial interests of these powerful actors and the public interest, in which these private interests would too often win out against the interests of taxpayers and patients and the public, that Colin and Jonathan and other academics who are witnessing this conflict up close decided that it was important to set up a new think tank which would use robust evidence-based research to help explain the consequences of this to the public and policymakers in terms which were easy to understand. And so here we are today. And so what I will do in the presentation is to first of all, just give you a little view of who we are. So as Charlie has said, in the brochure which is on your seats, you'll find an account of what we've done over the last 5 years. Here's a little set of photos of who we are as individuals, many of whom are in the room, apart from, of course, Colin, who can't be here, and Dave McCoy, who was our recent chair but is currently working for the United Nations and is based at this moment in Malaysia. Obviously that's me there, and Sid, our new researcher who joined last year, is also part of the team. So we're not a huge bunch of people, but we have sought to have a fairly big impact over the time that we've been working. So what I'd like to do for the rest of the talk is to give some examples of where we've sought to explain how the public interest has been subverted in the areas of health and social care, and how market-based mechanisms have impeded the ability of governments to meet the health and care needs of the population. And we've obviously witnessed that over the last couple of years during the pandemic. But what I also want to show is that we've not just sought to identify the problems that we have encountered, we've also attempted to come up with reasonable, cost-based, evidence-based solutions. Having worked as a policymaker at a certain level, I always saw policy as a problem-solving activity. And so whilst there are many organisations who will identify problems, not all of them will seek to identify problems and come up with solutions as well. So in each of the reports that we put together, we seek to ensure that we've got some recommendations in there that will address the problems that we found. So going back to 2013, and it is, I think, quite relevant that this is exactly 2 years to the day when lockdown restrictions were introduced in the UK, to say that back in 2013 we identified the potential for the NHS and social care not to be prepared for a pandemic. It's fair to say that when we raised these concerns at that time, nobody really listened, and we were considered to be scaremongering by some people. But our analysis was, I think, quite relevant in that what we were witnessing in the shift of the NHS to a more market-based system was that having that type of healthcare system in the face of a public health emergency is the one that we faced over the last couple of years. And that is not just something which has existed within the NHS, but within social care more generally, that you are less well equipped to be able to meet the challenges of being able to respond to that pandemic in a way which would save lives and improve the quality of the services which would be delivered, as well as to ensure there was some coordination right across the system. So this was an area where we identified that conflict in terms of how the market-based approach was putting the system, which was not just designed for delivering healthcare on an everyday basis, but to provide resilience and health protection for the population. More recently, over the course of the last year, what we've sought to do in terms of understanding the pandemic response is to think, okay, so all of the initiatives which have been used by government to actually prepare and respond to the pandemic, to what extent have those actually delivered in terms of value for money? And Sid's excellent report, which I suggest you read, looking at the deal between the NHS and the private hospital sector, which was around £2 billion, showed that it did indeed deliver quite poor value for money. PFI, profiting from infirmaries, I'm quite pleased with the use of that acronym. We went through the accounts of all of the various PFI companies that were providing services to the NHS, and we found that over a 6-year period, £831 million had leaked out of the NHS in the form of PFI profits. And from an organisation that is interested in the public interest and that conflict between the public interest and the private interests of different financial institutions and investors, I don't think there's a more obvious classic case study than PFI, because that extraction of money from the NHS not only is ensuring that there aren't sufficient resources to be able to provide care to patients or to ensure that the infrastructure of the NHS is updated, but it's also something which lands on individual hospital trusts. So my hospital in Walthamstow, Whipps Cross, is part of Barts, which has an astonishing PFI debt burden, which it has to service irrespective of any of the other demands which are placed on the trust. We've also worked looking at the issues of conflicts of interest in the UK healthcare service, and this is something which was covered in The Guardian just recently, where the relationship in terms of conflicts between the clinicians who are providing services and the interests of their patients are brought together in terms of attention because of the fact that financial incentives are being increasingly used by private healthcare companies operating not too far from here to bring those consultants to work for those private hospital companies, providing shares within the companies they work for, providing significant private hospitality services. It's something we're not very used to in this country. It's not something we ought to ever get very comfortable with. But what we don't have is a very effective and strong regulatory framework to be able to protect the public interest against the threat posed by these financial incentives. Okay, so I'm going to just pause there for a little bit, because I thought after having done a bit of talking, it might be useful for everybody to sit and watch a bit of TV, because I think that's what we've got used to over the course of the pandemic. So I'm going to just play a clip, which is a good example of how the work that we did looking at promoting the public interest in the care home sector led to some coverage on Newsnight, and I think it's actually quite good for maybe to see that in full.
Rosswell Care Home in East London used to be where survivors of the Blitz spent their final years, but no longer. In June last year, residents here found themselves looking for a new home. Theirs was closing. The site's landlord and the private firm who ran it had failed to agree a new lease. They had 56 days to move out.
I suddenly got a phone call at work in April, which was about just over 3 months since my mother had been in the home, saying that the home was going to close in June.
Hetty Lazarus was a teenager during the Blitz. She entered the home in December 2017, had to leave it 6 months later, and died earlier this year.
She was 93. She was obviously getting on, but she wasn't actually sort of senile or had dementia at that stage. You put someone into a nursing home, you certainly expect that there would be a longevity of, for her.
For some, what happened at the care home here resonates far beyond Walthamstow. It's a story about how much of our care sector is at the mercy of the whims of private equity firms, and how hundreds of millions of pounds a year are hemorrhaging out the sector.
The councils will have access to new funding of £1.5 billion for social care next year.
The Health Foundation think tank has told Newsnight that in fact £4.4 billion per year will be needed by 2023 just to stabilise the market.
All we have now is a sticking plaster of £1 billion, which will leave this sector in the same sorry state as now.
Newsnight has had first sight of the largest study ever undertaken into care home finances, an analysis of the accounts of 830 adult care home companies.
Even allowing for private providers to make a reasonable profit, this report says that about 10% of the £15 billion in fees that providers receive from residents and local authorities is never reaching the front line. The new £1.5 billion pledged by the Chancellor, that's how much is already leaking out.
They've shone a light on how some of the financial giants of the care home sector are spending hundreds of millions of pounds worth of fees on repaying their debts and maximising their profits. The study by the Centre for Health in the Public Interest, part funded by Unison, reveals a pre-tax and deductions profit rate of £7 per 100 for small and medium firms running care homes. But for the 18 largest for-profit providers, that figure is more than double. Former senior health regulators are behind the report.
Hundreds of millions of pounds a year leak out of the care home industry in the form of rental payments to offshore landlords, in the form of profit, in the form of management fees, and in the form of rental payments, again to offshore companies. Lots of debt has been loaded onto large care home companies by the companies that bought them and then loaded the debt onto the company, and that means in some cases that 16% of all the money which is given over to care for a resident each week disappears out of the system to pay off those high cost loans.
The average interest rate paid by the major care home operators in 2017 was 11.8%, which means that they were paying over £235 million a year in interest. And that's money that could be going to frontline care, but isn't. And there are estimates suggesting that that interest financing model is pushing up the cost per week for a resident in a care home by anything between £100 and £200 a week.
Four Seasons refused to comment on the closure of Ross Wilde. They are now trying to restructure, having gone into administration. For those in the homes, it means uncertainty.
It's not sustainable at all. I mean, one of the most worrying aspects is that all of the major care home operators, the big four, have been up for sale for an extended period of time, and none of them can find a buyer. That tells you all you need to know about just how risky this model is and how fragile the industry is. And if one of these major care home chains fails, you're going to have the security and the welfare of tens of thousands of vulnerable old people on your hands.
The opacity of the current care home system meant the study was hard to do. The CHPI is pushing for more transparency so residents, who account for more than half the fees, and the public know how their money is being spent.
They have a piece of legislation in America which is designed to require all of the care home companies which are providing state-funded care home services to account for where all the money which they receive ends up. and we're suggesting that that is something which should be introduced in the UK.
What we found overall was that there was a significant amount of leakage that was going on, that was going from the money that was going into the care home sector, which was designed in order to be able to provide care services for older people. A significant amount of that money was leaking out of the system, away from the front line, away from caring for older people, away from the care workers who were operating often at very low pay, and towards companies that were registered offshore. We looked at issues around, for example, management fees, where £200 million a year was disappearing out of the system just in terms of management fees. £200 million which was allocated by those people who were purchasing the care on behalf of older people or people who were paying for themselves, which they expected to go directly to care for older people. So at some point we'll get the clip back up, or you can have a look at it on YouTube, but that really is the kind of the nature of that particular study that we carried out. One of the interesting things that isn't covered in that clip that I just wanted to follow up on, so the care home which Deb Cohen was stood outside of is just down the road from where I live in Walthamstow. It's now no longer there. It's now been converted into inevitably a block of flats. But at the time that the council were seeking to work out what to do with all of the residents who were being paid for in the care home, they got in contact with me and with the local MP and said, we don't know who owns this building. We don't know who the landlords of this property are, because we need to be able to negotiate with them and engage with them, so perhaps we can extend the duration of time that we've got before the residents have to be evicted. So we looked into it, and we found that there was a property company that was registered in Jersey, which gave us absolutely no understanding about who actually owned the property. But we knew that it wasn't a property that was owned by a UK registered company. More recently, and with SID, we've started to look in more detail at that. We know there are hundreds and hundreds of care homes which are owned overseas by companies whose provenance we cannot be sure of. And that's, again, one of those examples of where the interests of those residents and the interests of the workers who operate in those homes is coming into direct conflict with the financial interests of those companies that own the homes and also those companies that operate out of them. Okay. So we'll see if there's another clip that can be run.
Mary Greaves's brother Peter had a hip replacement in January last year.
He was one of many NHS patients treated in a private hospital. An inquest found he wasn't transferred to an emergency unit quickly enough when his condition worsened. Matthew Bone reports.
I came back home and I just walked in the door here and the phone was ringing and they were saying, can you come back? Your brother's gone into cardiac arrest and we're trying to save him. He never regained consciousness and died 2 days later.
Mary's brother had a hip replacement paid for by the NHS but done in a private hospital. An inquest found Peter's operation had gone well, but when he became ill during his recovery, mistakes were made at Beaumont.
Unlike many NHS hospitals, private hospitals don't tend to have an emergency department on site. That's the case here at the Beaumont. So if there are complications, patients are transferred back to an NHS hospital. The inquest found that, in Peter's case, that didn't happen quickly enough.
BMI, which runs the Beaumont Hospital, said in a statement, "Our condolences remain with the family and friends of Peter O'Donnell. In the 20 months since his death, we have made a number of changes at the hospital. Our principal objective is to provide safe and quality care for all our patients." But Mary says it's wrong to perform these kinds of operations if there's no emergency department at the site.
All surgery is not without a risk of some sort. There needs to be some emergency facilities in places.
Hundreds of thousands of NHS operations are done in private hospitals every year to help deal with waiting lists. Supporters of outsourcing say standards can be higher in private hospitals, and as long as the right procedures are followed, it's safe to transfer patients who end up needing emergency treatment.
for many surgical procedures, and the vast majority, frankly, that they can be treated safely in a hospital without intensive care facilities, providing that the preoperative work is done properly, the screening is done properly, and the right patients are seen in that facility.
But the right procedures weren't followed for Mary's brother, and the consequences have left a big hole in her life.
It's difficult to accept a death when you know it might never have been. It's just sad, that's all. I just find it really, really sad.
Matthew Bone, BBC Northwest Tonight.
The reason for showing that clip, apart from the fact that it does bring to life, I think, some of the tragedies that one sees in terms of the deaths that occur as a result of patient safety incidents and the people who are left behind and affected, is because the background to that story was that when Mary was going through the coroner's inquest into the death of Peter, she was doing her best to try and understand how it was possible for Peter to have been treated in the way that he was, where there were no proper post-operative facilities in place and arrangements in place in the event that something went wrong with his care. And so Mary, being a very smart former head teacher of a primary school in Salford, found our report on the internet, and she gave it to the coroner. And the coroner looked at the case of Peter's death, looked at what had happened, and saw that the systemic patient safety risk that we had identified in our report, which was put together when we looked at over 170 CQC reports into patient safety in private hospitals, that the particular example of Peter's death in that instance matched very closely to lots of the systemic patient safety risks that we had identified. And so when the coroner came to report on Peter's death, he has a power to notify certain authorities of actions to be taken in order to prevent future deaths. So he wrote to us and he wrote to Jeremy Hunt. And he said, this is what happened in this case. This is what is happening quite frequently in private hospitals. These are patient safety risks that need to be addressed. And so as a result of that, Jeremy Hunt then wrote to the private hospital sector and told them, according to his letter, in no uncertain terms, to get their act together on patient safety. This was back in 2018, and nothing happened. We're also now in a situation where the government has finally come back with a response to the Ian Patterson scandal, which was the initiation of our work around patient safety in private hospitals. And we've got Debbie Douglas in the audience, who has just done incredible work in pushing for changes to patient safety in private hospitals, and not just doing an amazing job of being able to push for justice and compensation and changes for the thousands of individuals that have been affected, and has done so with a shocking lack of support, I think, from across the medical profession and the regulators and from parliamentarians, but has also sought to continue to raise this issue about why it is that the changes which need to be made to patient safety in private hospitals is not happening. And again, in that instance, what we see is a very strong conflict between the interests, the business models that exist that allow private hospitals, for example, to deny liability for when things go wrong in their hospitals, to employ resident medical officers who are junior doctors who are working 24/7 on very, very low rates of pay. And probably everybody has watched Adam Kay's programme where he explained some of that in more detail in terms of the actual impact of those poor post-operative cases. And we're now in a situation where the government is increasing the use of the private hospital sector to deliver more and more NHS operations. So this conflict and tension between the interests of the public and the safety of the public and the financial interests of the private hospital sector in particular are becoming more acute, are becoming more problematic in terms of the issues that we face going forward. So just to conclude, first of all, I want to say thank you for your ongoing support and also thank you for sitting through the technical difficulties that we've experienced. I think it's really important for ourselves to continue to exist and to continue to build and develop and to expand the networks that we've been building upon over the course of the last decade. It would be really helpful to have all of your support, and there are many people in the room who have contributed to that over the years, but it is quite frankly a moment within the future of the NHS and social care where we're going to be challenged more and more by these conflicts between the public interest and the financial interests of other organisations, because of the fact that, one, the government is very relaxed about the expansion of for-profit healthcare in this country, and two, because of the fact that the public are not very aware, as things currently stand, about what that actually means and the cost that it's likely to have in terms of the future of the health service in this country. So I will hand over now to Jonathan, who will hopefully chair us through the remainder of without any technical issues.
David, thank you very much.